My name is Karen Patrick. I'm an occupational therapist working in the Transitional Care Unit at Coosa Valley Medical Center in Sylacauga, Alabama. I have previously worked in the inpatient rehabilitation setting and in acute care. Most of my caseload currently consists of geriatric patients with a variety of orthopedic, neurological, and general debility diagnoses. I would estimate that well over half of the patients I work with have low vision as a comorbidity. Most people affected by low vision are older adults over age 60, with 1 in 4 adults over age 80 being affected. The number of individuals with low vision will continue to grow as the population ages. Low vision is often a contributing factor leading to a patient's hospital admission. However, it can be a hidden disability because an individual frequently doesn't show any outward signs of impairment and manages to get by without attracting attention to their condition. Many times low vision goes undetected until the affected individual makes a critical error such as misreading a medication label, tripping over an unseen obstacle, or turning an appliance to the wrong setting. This leads to injury, which then compounds the issue because the person with low vision now has another condition that requires treatment. Low vision is visual impairment that is severe enough to interfere with daily activities while still allowing some usable vision. It cannot be corrected by eyeglasses, surgery, or traditional treatment methods. The most frequent causes of low vision among older adults are macular degeneration, diabetic retinopathy, glaucoma, and stroke. In working with patients, it is important to recognize the impact that each of these diseases can have on vision. Each of the previously mentioned conditions affects vision differently and causes different challenges during the completion of daily activities. Macular degeneration, the most common eye disease among older people, results in blank spots in the middle of the visual field. It damages the macula, the portion of the retina which gives the most detailed vision, but it does not result in complete blindness. Diabetic retinopathy causes scattered blind spots as well as blurring or loss of peripheral vision and can quickly lead to blindness if not controlled. Glaucoma causes loss of peripheral vision resulting from the buildup of fluid in the eye, which causes pressure on the optic nerve. It can result in blindness if not controlled. Stroke or traumatic brain injury can result in a loss of portions of the visual field depending on the affected area of the optic nerve or the brain. A quick review of a patient's medical history can give clues as to what types of challenges the patient may be facing and how to best help them face these challenges. The loss of the central visual field has the biggest effect on reading or other activities requiring attention to detail, while the loss of peripheral vision can have a significant impact on mobility due to a decreased ability to anticipate hazards approaching from either side. If you are working with a geriatric population, it is important to remember that visual acuity and contrast sensitivity do decrease with age, even if an individual has not been diagnosed with a disease leading to low vision. In fact, most older adults require 3 to 4 times more light to complete daily activities than younger people. Most individuals with low vision have lived their lives with normal vision and must now adapt to a different way of completing their daily activities. This can be a huge adjustment for the average person, since we receive over 90% of our information about the world around us through our vision. When our ability to obtain visual feedback from the environment is decreased, we are not able to obtain information as quickly in order to make decisions and anticipate potential hazards. We are forced to either use our other senses to gather information more slowly or rely on other people to provide it. Depression can often occur as a result of the drastic lifestyle changes brought on by low vision. It is very important to consult with the patient's doctor or mental health professional if you think your patient may be depressed. As an occupational therapist trained in low vision rehabilitation, It is my goal to help my patients complete the daily activities that are important to them as safely and independently as possible. There are a variety of ways you can assist your patients with low vision. First of all, don't be afraid to be direct about vision by asking what your patient can or cannot see, and don't worry about using phrases that emphasize vision. It is especially important to orient a patient with low vision to their room and help them identify how to push the call button to ask for assistance, how to operate the bed, and turn the lights off and on. Remember to identify yourself and let your patient with low vision know when you enter and exit the room. Another important thing to remember is to say everything you want to convey, realizing that the person with low vision may not be able to see your facial expressions or read your body language. When writing something to be read by someone with low vision, it is helpful to use a black felt tip pen and print in clear lettering. Try to keep the environment predictable and uncluttered by keeping frequently used items in a designated place, returning items to where you found them, and keeping drawers and cabinets closed to avoid injury. Your patient may require assistance when presented with their meal tray. Seasoning and utensil packages may be especially difficult to locate and manage on a tray since they tend to blend in with the background. Patients may also need assistance cutting up food and identifying the food items on their plate. One method that can be helpful in patients with severe visual deficits is to treat the plate like the face of a clock and identify the location of the different foods as they correspond to the numbers on the clock. For example, tell them the fish is at 12, the potatoes are at 3, the green beans are at 6, and the bread is at 9. When assisting with mobility, it is better to offer your arm rather than grabbing onto the arm of the person with low vision, since you risk throwing them off balance. Avoid doing everything for your patient, and don't automatically assume they're not capable just because they can't see. In working with patients of any age who wear glasses, whether they have low vision or not, one of the best things you can do is make sure they have access to their glasses and that their glasses are clean. I've been amazed many times at what a difference it makes to my patients just to have clean glasses. If a patient is used to wearing glasses all the time, it just handicaps them further if they aren't able to wear glasses that are in the best possible condition. Many times they are rushed to the hospital without remembering to grab their glasses. It can be very helpful for you to advocate for the patient and ask a friend or family member to retrieve their glasses for them from home. Most of the patients with low vision that I've worked with appreciate being given the chance to do as much for themselves as they are safely able to do. They are still very capable individuals who just require a few adaptations in order to be as independent as possible. I have found them to be very inspiring and innovative people, and I hope that you will enjoy working with them as much as I do.